Great job, Eugene. The power of HA Youth right there on display. Fantastic. Well, next we have a real treat because as part of leveling the playing field, we have two of our executive committee members, Miss Sarah Smith and Miss Fiona Wardman. They're going to come up and they're going to talk about something very, very important. One of the things that empower us as HA patients is information and understanding the fundamental aspects, the key aspects of HAE is really, really important. And today, they have selected certain things that we must absolutely know about hereditary angioedema, and I dare say that if you do absorb the information that you're about to receive from Sarah and Fiona, you'll probably know as much as 80% of the doctors out there. So ladies and gentlemen, please welcome Sarah Smith and Fiona Wardman.
Hello, good morning, good mid-morning. Welcome all to Vienna. Fiona and I would like to say a few words about actually the basic things one should know about HAE. I think to really take control of a rare disease like HAE, the patient really has to know what's going on. Because, as Tony says, most of the doctors out there don't really understand either. So we'll start HAE as opposed to, next slide. HAE as opposed to an allergic angioedema comes from a different route. HAE types 1 and 2 are caused by a genetic defect, a mutation, which results in a deficiency of the C1 inhibitor protein in the blood. In HAE, this is another field we're now getting into. HAE with normal C1 inhibitor, what we were calling type 3 HAE, is still in the process of being researched. There's not a very good understanding of what's going on there. There has been identified a mutation in coagulation factor 12, but there are other mutations in other places and other genes that it's a hard type to deal with.
Good morning, everybody. So HAE is an autosomal dominant inheritance pattern. So that means that one parent must have the defective gene to pass that on to their offspring. It does not skip a generation. However, like me, I am the only one in my family with HAE, so it starts, don't have children, so it stops with me. If I was to have children, that dominant gene would pass that, or could possibly pass that on to any offspring, and there's a 50% chance of that happening.
And in most cases, when there is a suspicion of HAE, recurrent swellings that cannot be controlled with typical antihistamines or the normal medications for allergic disorders, then a blood test will usually confirm an HAE diagnosis. And genetic testing really is not required, but there are always doubtful cases, and of course in cases of what we call de novo mutations, spontaneous mutation, where like Fiona is the first one in her family to have it, would be the case of a mutation that occurs suddenly with no family history. And in those doubtful cases, the physicians will recommend genetic testing. When there is a suspicion, they'll usually, a doctor that understands will usually want to test for the C4 first, the complement 4. And if that is, usually with that diagnosis, with that test, if the C4 is low, is not a normal value, then they would go on to test for C1 and other factors, and that, in most cases, will confirm a diagnosis.
So it's always important to know that an HAE attack is not an allergic reaction. So it's not from a mosquito bite, and it's not from a bee sting, and it's not from eating a peanut. It is a genetic disease. So you can see on the screen up there the allergic response for allergic angioedema. So there's the antigen and the mast cell, which covers up the process, and then it releases the histamine and other inflammatory mediators, and then that causes the swelling.
Which is why I think many of you have probably been through attacks when all they treated you with were antihistamines, and they do not work. Corticoids, the typical antihistamines, corticosteroids, adrenaline, none of that works for you because histamine is not the reason that your system is being activated and the swelling is occurring. It's caused by something else, bradykinin.
So this slide shows the difference between an allergic reaction on the right-hand side, and on the left-hand side, the graph there gives you the path of hereditary angioedema. So you can see the different, the factor and where the C1 inhibitor is reacting, and then how the process goes down. So the swelling is released by bradykinin. So that's what causes the swelling.
Yeah, there's a series of mechanisms that lead up to the increase in bradykinin, and with the bradykinin, that large amounts, that's when the cells begin to open, the fluid is released, and the swelling occurs. And of course, you all know that the swelling of the mouth, tongue, and throat are medical emergencies. They should be treated immediately. But as Tony and Henrik have also said now in the new guidelines, they're saying most swellings, all swellings, should be candidates for on-demand treatment. An abdominal swelling can be extremely dangerous. I didn't realize that in the beginning. When my daughters were diagnosed with HAE, I thought, well, it's painful, but they'll get through it. Abdominal swellings can also be very dangerous. Swelling anywhere could lead to swelling eventually in the face, the throat. So yeah, I think people have to realize that all attacks, all episodes, wherever they are, should be considered for treatment.
So this is a list of the modern HAE therapies that we have available. So Cinryze and Berinert are a brand of C1 inhibitor esterase. So Cinryze is IV prophylaxis, and Berinert for IV acute attacks, and in some countries also prophylaxis. Firazyr icatibant is a brand of bradykinin receptor antagonist, which is a subcutaneous injection, which is given into the stomach or thigh or wherever is comfortable for you. Kalbitor is only in the US, and it's a brand of plasma kallikrein inhibitor, which is also given subcutaneously. Ruconest is a recombinant human C1 inhibitor, so it's not made from human plasma, and it's used for it's acute attacks also when it's IV. And Haegarda is something that's out there, fortunately for some of you. Some of us are hoping to get that soon. And that is a C1 inhibitor, which is subcutaneous for prophylaxis, so then there's no more IV treatment.
Then we have things coming onto the, research and things that may be coming to the market fairly soon. Shire, which has been, the acquisition, Tony, has gone through, right? It's still Well, by Takiro, the Japanese, a big Japanese pharmaceutical company. Shire is still testing a long-acting subcutaneous treatment for prophylaxis, 1 or 2 shots a month, very good results. Pharming is testing for their recombinant C1 inhibitor for prophylaxis, and that's being reviewed in the United States, at least now, by the Federal Drug Agency. BioCryst still has ongoing trials for their oral treatment, very promising results up to now. CalVista is also developing candidates for oral treatment, just taking a pill, so no more shots. Very promising. I'm not too familiar with Adverum. It would be gene therapy for HAE. And there are several other companies working in the HAE space. I think from the very beginning, as a rare disease, HAE has been lucky in the sense that there have been several pharmaceutical companies interested, have invested heavily in developing treatments, and more people are still coming on board with possible new treatments for the future.
Yeah, I think we're a very lucky bunch of patients to actually have HAE with all of this new research and new options coming our way. So patient organisations create a spark for gaining access to therapies, and I know that that is true in my own country, Australia, and also we're doing work in New Zealand. So patient organisations create that patient voice to go to the pharmaceutical companies to work with them as well, and to also go to the governments to make sure that they understand what it is to be an HAE patient, how we can improve our lives by gaining access to different therapies around the world, and not all therapies work for everybody. So we all should be fighting. Even if we have one, we need to fight for all of them. So success is achieved by intelligent use of available resources. So HAEI have a great amount of information and resources available. There's physician advisors, use your local consultants, that one champion doctor that you have in your area that is passionate about making a difference for you, grab them and get them under your wing and fight together, because if we have more voices, we can make a lot more noise. Work with the government officials, get to know them, and we'll talk a bit more about this tomorrow. But work with your government officials, not just when you need something, but let them know, send them stories. The pharmaceutical companies are vital in getting these therapies across the line. We need to be able to have them accessible so that we all can live a normal life. And crafting a sound argument for HAE therapies by demonstrating the dramatic improvement of quality of life. We often just think about, great, I need the treatment so that I can go to work or I can go to school. But having those treatments available to us makes us a lot more independent. It gives us much more hope. It makes us less stressful in getting the next attack. So if we're able to have those therapies to hand, we can just move on in our lives and not think about HAE as being something that we need to worry about too much. And sustained effort. We will lose some battles. We've all lost some battles. You've lost some battles in Spain. We've lost some battles in Australia and New Zealand, but you have to keep fighting. Don't give up. Just keep looking at those other people that you work for and you're working with. Everyone has an amazing story. Grab that and run with it, and don't give up.
Okay, well, I think that now we're all qualified to prescribe medicine as healthcare physicians, so great job, guys. I think those are the 10 really fundamental things that if we all understand, we can help take control of our hereditary angioedema. So here's some good news. Looking at my handy